Welcome to Good Tech, Compassionate Healthcare, an AMS healthcare podcast that explores the convergence of technology and compassion in healthcare. We host conversations between leading researchers, scientists, and healthcare providers as they confront the challenges threatening our current and future healthcare system, especially in the face of the pandemic. We see an incredible opportunity for digital health to innovate medicine and clinical care, healthcare education, home care, and beyond. That said, we hope to foster an open-ended discussion about how to integrate technology into the healthcare system in a way that enhances and doesn't diminish compassionate care, ultimately improving the experience of patients, caregivers, and healthcare providers alike. If there was ever a time to uphold compassion as the bedrock and guiding principle of healthcare, it's now. Join us now to explore Good Tech, Compassionate Healthcare, brought to you by AMS Healthcare. In this conversation, Ed Spilg, Geriatrician at the Ottawa Hospital, Research Chair in Physician Wellness at the University of Ottawa, and an AMS Phoenix Fellow, and Cynda Rushton, a nurse and professor of bioethics and nursing and medicine at Johns Hopkins University, discuss moral distress, moral resilience, and mental health in healthcare workers amidst the COVID-19 pandemic.
I'm Ed Spilg. I'm a geriatrician in the Division of Geriatric Medicine at the Ottawa Hospital. I'm also an assistant professor and research chair in physician wellness in the Department of Medicine at the University of Ottawa and a senior clinician investigator in the clinical epidemiology program at the Ottawa Hospital Research Institute.
I'm Cynda Rushton. I am a nurse and I am a professor of bioethics and nursing and medicine at Johns Hopkins University. And I have been studying for many years now the issues around clinician suffering, moral suffering, and how they respond to those challenges and the moral residue, and have had the wonderful privilege of working with Ed on some interventions aimed at helping clinicians to address their moral suffering in ways that supports their health and well-being.
What do you think when you look back on this pandemic? What do you think your sort of overarching thoughts are going to be?
Well, there's lots of different ways to answer that question, Ed. I think one of the reflections I would make is it's been a time of incredible paradox. On the one hand, we have seen examples of compassionate care where people have shown up in really hard circumstances to do the right thing and to do it in a way that has been compassionate and caring. There have been acts of courage. There have been incredible sacrifice that clinicians have made to care for so many people that have been impacted by the COVID pandemic. And on the other hand, there has been a lot of suffering. There's been suffering around the world by people impacted by this virus, but there's also been a lot of suffering on the part of clinicians. That leaves a real wound for many clinicians that I feel like will take a long time to heal. Part of our challenge, I think, is to be able to accurately understand the reasons for that suffering and how we can be more precise in our diagnosis of what has caused that suffering and to target interventions that are specific to addressing that. And, at the same time, it is a time where ethical issues used to be episodic, and now they are chronic and unrelenting. And so I think we have some real opportunities to step back and think about what did we learn and how might we leverage that going forward to create healthcare systems that are inclusive and respectful and actually that support the humanity of everyone, including the people who are delivering care, which I think has not been in the equation to the extent that it needs to be up until now.
That more than answers my question. I mean, for me, it's been quite an interesting journey. I've been a researcher predominantly in the field of physician wellness now for the last 7 years, I would say. I was an AMS Phoenix Fellow in 2016, and I particularly studied the impact of burnout on physicians and how this impacted the delivery of compassionate care that they provide to their patients. And for my journey, it's been interesting in that really up until March 2020, most of my work focused on the impact, as I said, of burnout rather than the impact of moral suffering. I've been focusing a lot of my research in this area, and I've been well aware, particularly in the nursing literature over the last 20 years, about the challenges that nurses have faced with moral distress. But what's really kind of interested me is how the worlds have collided, if you like, between nursing and other areas in healthcare, where everybody has now suddenly found themselves in the same situation, where we've been asked to suddenly, first of all, cope with an unknown disease, a disease that nobody really knew anything about. Nobody knew what the impact was. I'm not sure whether we even realized there was deep moral suffering at the very beginning. I think we were just so taken aback by the speed of onset of this condition. Everybody was just so uncertain of what was about to happen. And as we were grappling with all of this, I feel that, you know, myself, yourself, and so many other clinicians and scientists around the world have suddenly started to become interested in trying to study and understand more about this problem, because as many people have said, this isn't a problem which is unique to the pandemic situation, but it's been certainly put under the spotlight because of the pandemic. But almost certainly once we're over the pandemic, which hopefully we will be at some point in the next, 12 months, more maybe, there's going to be a huge amount of moral residue that's going to be left within healthcare that we're going to have to deal with. So yeah, it's an interesting period to be able to reflect on this. From your personal perspective, what have you witnessed? What have you seen in your colleagues? What have you seen them going through? How have you seen them suffer?
Wow, a lot. It's interesting what you're describing, Ed, fits really well with our understanding of one type of moral suffering, which is really been understood first in the military, and that's moral injury. And one of the features of moral injury is that when our core values are threatened or violated in some way, it begins to erode our sense of moral identity. Who am I? Am I still a good person? Am I still a good nurse or good doctor? What often happens is we don't even realize in the moment what's happening. And it's only when we finally get to a place where we can pause and take a breath that we realize, oh my gosh, what have we participated in? What have I witnessed? And what I've heard from and seen in my colleagues and nurses in particular is a sense of betrayal. That on the one hand, nurses in particular were asked again and again and again to show up, to fill the gaps in how to meet the incredible crush of people who needed care. Early on, when PPE was scarce, it was often nurses who were relegated to use the PPE and to go into the rooms with patients infected with COVID, as other people stood outside the window and looked in. And that began to feel as if my life is less important. And so I'm being asked again and again to take risk in my own health, but I don't have the resources to keep myself safe. As the pandemic sort of unfolded, there were other kinds of betrayals, So nurses, for example, obviously the largest segment of the healthcare workforce, when there were shortages, the people who had just been providing care for 12 hours were the very people that were called at the end of their shift. Can you come in again? Can you come in on your day off? Can you work over? And that began to also feel as if there was a disrespect of their need to renew themselves, to recover so that they could come back for their next assignment. And then you sort of add on what was happening in society, and what was happening in the United States was a huge social unrest around social inequities, structural racism that was showing up, and violence against people of color. And all of that was also part of everyday experience, where you saw upfront and personal the impact of those social inequities on people, the people who were sick coming into our emergency rooms and into our intensive care units were people of color. And that also began to fuel a kind of distress in the midst of our political divide, where what happened over time was people who were rejecting public health guidance, who didn't want to wear masks, who didn't want to follow visitation policies that limited the number of people that could be in our settings safely, who didn't want to get vaccines, began to turn that anger toward the very people trying to provide care. Nurses are the ones who are there 12 hours a day, and they are the ones who often bore the brunt of having to deliver the message that, no, I'm sorry, you can't come in, and also bore the disrespectful language and often physical violence against them. So when you think about that whole combination, you can see how it can begin to erode your sense of worthiness as a person. And so that's the kind of moral wound that I think many, many clinicians are carrying, that they began to feel betrayed by their organizations, that you didn't keep me safe. And even related to that, one of my dearest colleagues, who's a critical care nurse, worked nights, day after day after day. And she finally realized that she had gotten to a point where she was experiencing PTSD. She was depressed. She asked for a leave of absence for 10 weeks in an organization that promised to have mental health resources available. It took her 9 weeks to get an appointment to be seen. So these kinds of cumulative betrayals are going to have a very significant impact on our workforce. And in nursing, we're seeing it in the United States of nurses leaving their jobs, and in some cases, sadly, leaving the profession because of the problems that were present before have only been exacerbated now during the pandemic.
Sadly, we're seeing a very similar picture in Canada with our nursing colleagues. I'm interested in this notion of moral distress in physicians in particular, as we discussed. Moral distress was described, 30 years ago or so as really and there's many different definitions of moral distress, too many to read out, but one classic one is a psychological response to an experience of moral conflict or moral constraint, which often more likely to occur during something like a public health emergency, where there's extreme resource limitations and where patient care and healthcare worker safety may be impacted. But in terms of when it occurs, it's been interesting for me because the literature hasn't really written about moral distress in physicians until the pandemic began. the literature on physician wellness focused predominantly on burnout and the implications thereof, both in terms of how it impacts patient care, both in terms of quality of patient care, how it impacts the delivery of compassionate care, but also how physicians who are burnt out are more likely to make errors, are more likely to be disruptive in their workplace, and more likely to quit the profession or unfortunately participate in substance use and develop substance use disorders. But we didn't talk about moral distress in physicians, although increasingly, maybe over the last 5 years, we've seen more literature on moral distress in learners, particularly in the intensive care setting. And for me, I've often wondered whether this is because of the role, the hierarchical role that we have within healthcare, and particularly around who's making decisions, who's writing orders, where traditionally it's the attending physician who decides and writes the orders, and it's the role of the nurse and the learners to some extent to follow the orders that are written. And so the person who writes the orders, who's got some degree of autonomy and control over a situation, is probably more likely to be the person who's most comfortable with the orders. The thing that I've become most aware of is that over the last 20 months or so, so much control has been taken away from everybody in healthcare. Nobody's really controlling this situation. There's very much a sense of we're being reactive, whether it's the first wave, second wave, third wave, fourth wave. Are we on an uptick? Are we on a downtick? Are we on a level? Nobody quite knows what's going to happen next. The experts are telling us what they think might happen next, but nobody really knows. We've heard of triage protocols, which in some places have had to be implemented, but fortunately in many other cases, these were never implemented, although just the prospect of them caused very high levels of moral distress in many of my nursing and physician colleagues and other colleagues in healthcare. So all of a sudden, I think what we've seen that's changed, and the shift that we've changed in the narrative in the last 20 months, is that everybody's now having to make decisions which oftentimes they're not comfortable with. Everybody's being involved in having to feel that they are in some way, at some point in time, they have felt complicit in wrongdoing, where they believe that they are doing the wrong thing and have little power to change the situation that they find themselves in. They often feel that they don't have a voice, that they lack the moral agency. They believe that they have the expertise, the insights, the knowledge relevant to the situation, but when they try and voice that their voice either isn't heard or they're maybe not taken seriously. And of course, we know that it's not about voices not necessarily being heard. We know that there's a lot of noise going on in the background, and there's a lot of people trying to do an amazing job and trying to keep healthcare moving forwards. But the impact that even if it's just a perception on individuals, can, I think, have quite a negative effect on them in terms of contributing to that moral suffering.
I think you're right on, Ed. It's interesting. I don't think it was just the pandemic that has revealed a shift in physician authority. Physicians typically have enjoyed a great deal of authority and autonomy. And increasingly, at least in the United States, physicians have become more and more employees in healthcare organizations, which means that they're not the captain of the ship anymore. It is the case that it constrains their ability to make independent decisions. And they're more like the position that nurses and trainees have had in terms of implementing the decisions of others. And so in some ways, that has equalized the playing field a bit and has opened the door for really examining the context where we have to make decisions under constraint. I hope that this is an opportunity for us to think about how do we join together in solidarity and our shared commitment to the people that we are called to serve. because to me, that is the thing that ties us together. In many ways, part of what has been eroded for many clinicians is our patients are what give us the fuel to keep coming back again and again. And unfortunately, many healthcare organizations have co-opted that commitment and corrupted it by expecting that they can provide environments that actually are not conducive to the patient-clinician relationship, and people will still show up. Because what we've seen in COVID is I've had nursing colleagues say, you know what, I would do anything for my patients. But when my patients turn against me, when I feel that I am no longer valued as a member of the team, there's no motivation any longer. And this is why I think it's a moral issue, is that it tracks back to why am I here? Why am I here in the first place? To relieve suffering, to benefit people, to do so in a fair and just way. When I can't do that, I find it really difficult to keep resourcing myself to come back again and again. And that's the place where I think we have the opportunity to say, how do we restore the relational context of healthcare? And not only with our patients and families, but with each other. Because if you think about what's happened in this virtual world, we're not standing at the nurse's station anymore having conversations. We are communicating virtually, communicating by technology. And we have missed the human connection that really ties us all together. We've had some wonderful examples of how it has enhanced our communication. But like every kind of technology, there's the benefit and there's also the shadow of it. And so I think one of the opportunities is for us to think about how do we restore our relational integrity with each other, with our work, with our purpose, so that we do have the fuel to meet these challenges rather than to feel hopeless and to feel despairing about our work.
Absolutely. It's interesting how the narrative has certainly shifted, particularly over the last 20 months or so into the pandemic. I've often reflected over this time about moral distress, where a clinician feels unable to take what they believe to be the ethically appropriate and right course of action, which in their mind avoids doing wrongdoing or causing harm, and is often because of institutional obstacles or other constraints within the organization. But then I think back and think, ethics, moral stress is to some extent, it does add to stress within healthcare. It's integral to healthcare. I don't think you can have a healthcare system where that is free or devoid of moral stress. In fact, I'd be very concerned if there was a healthcare system that was being run where nobody experienced some degree of stress when they're confronted with moral situations and moral dilemmas. It's our compass. It's what makes us stop and think. It's that check to say, I'm faced with a situation. I'm just going to pause. I'm going to reflect on apply my own moral and ethical principles to that. And I'm going to make sure that A, I do the right thing, and B, my patient is comfortable with the decision or the action or whatever it is I'm making, and that myself and my team are comfortable with that action. For me, it's that line when we can manage that stress and we can work without any impact or any negative effects, as opposed to when that stress becomes greater and greater and greater, and it starts to cause us distress. And we've heard a lot of talk and a lot of great stuff that's been done to focus on healthcare worker wellness, during the pandemic. I suppose for me, the issue, though, is does the focus on wellness go far enough to address the stressors that people are facing when they're faced with moral situations which threaten their integrity? Does the subject of wellness go enough to address that? Or does it miss out an important moral dimension? And is that a risk going forwards, that unless we start to integrate this moral dimension into wellness, because we're talking about wellness in this whole sense, not just necessarily in the psychological sense, but also in the moral as well as the physical sense, we might try and address a wellness problem, and we think we've addressed wellness, but we've unfortunately missed the target.
I think you're right, Ed. Two things. The first is that moral stress and moral distress is, as you said, it's part of being a healthcare clinician. In a way, we don't want to extinguish that because it's a signal of our moral conscientiousness, that we are aware of the choices that we have to make. And the reality is we've always had to make hard choices, and it is part of the work that we do. The question is what of those moral conflicts are modifiable and which ones aren't? And how do we then identify them and design solutions that are specific in addressing the root causes? I agree with you that terms like burnout and in some ways wellness are sort of catch-all terms. We need more precision. We know that moral suffering can lead to burnout, but it's not the same. And applying the same solutions to burnout to moral suffering is likely not to meet the mark. So what I would say is that we need a more robust understanding of well-being that includes moral well-being. That is not the same as psychological or physical well-being, but it is in its own domain a separate category. So my own work has focused on the concept of moral resilience, the ability to restore or preserve our integrity in response to all these different types of moral adversity. And what we've begun to know in our research, some of which we've done together and others that we have done in other studies, looking at the relationship of moral resilience with moral distress and in a separate study on moral injury, is that there are capacities within us that are already present that can be amplified and can be a resource to us, not to be complicit or to overlook the very real ethical challenges that are present in our work, but to provide us with some resources to meet those challenges in ways that don't disable us. And so that's really the work I've been focusing on now for the last 4 or 5 years of how do we actually give people the tools to access what is already inside of them. This is not a deficit model. This is the assumption that we all have this potential within us, that we see wholeness. And so it's helping remember what those parts of ourselves that we resource ourselves when we're in these hard situations, and how do we amplify and strengthen those, rather than suggesting, well, you somehow are deficient or you've somehow failed. No, it's how do we access that within ourselves, but also importantly, how do we design systems that support people to do the right thing all the time without so much cost to themselves? And so we need individual strategies because we are the system. We're made up of people. And we also need intentional strategies to dismantle those systemic contributions that are the modifiable parts of the equation. And so opportunities abound, I think.
Very much so. I just wonder, though, whether, people who are listening to this will really appreciate how much of their wellness that's many people, I've spoken to many colleagues, many of whom will tell me that they feel their wellness has been challenged immensely by the pandemic. They'll tell me they're exhausted. They'll tell me that they're stressed. But I'm not quite sure whether people understand a lot of the triggers, or at least my observation of a lot of the triggers that is causing a lot of this exhaustion, a lot of this stress and distress originates from moral dilemmas that they faced in the workplace. I think it's because people have just kind of assumed that some of the decisions that we make day to day in healthcare are just so part and parcel of healthcare that we don't think of these as morally challenging situations. So I'll give you some examples of kind of things that, I've asked colleagues about when I say to them, do you feel moral distress in your workplace? They'll say to me, I'm not quite sure what that means. They'll tell me that they can't sleep at night. They'll tell me that they know that they've missed the opportunity to socialize, to connect with loved ones, with friends. They'll tell me that they feel that they're not enjoying their job as much as they did before. They'll tell me that they are feeling more detached, more isolated from colleagues, and maybe also more detached from patients. They'll tell me that they feel less able in some respects to advocate for their patients because they are just exhausted themselves and they've got less gas in their own tank, and they're having to preserve that to be able to provide care for as many people as they can. I think people just don't realize that what they're experiencing is moral distress. And is that a message that we need to get out? Because we're hearing a lot of headlines about healthcare workers facing moral distress. I suspect that maybe just is the tip of the iceberg, actually. When people actually appreciate what moral distress really is, they're going to be saying, yeah, that's exactly what I'm feeling just now.
Ed, it's so true. When I started in this territory, now decades ago, we didn't even have a language or a vocabulary to talk about these moral problems. I remember in 1992, I was giving a presentation to a group in a huge auditorium of critical care nurses, and I was talking about clinician suffering. And I described 3 different scenarios where really moral suffering was present. And the room was completely silent. And I thought, oh no, this is a bad sign. What happened was afterwards, people said, I never had a word or a phrase to describe my experience. And I think that's part of what we're seeing right now is we have used code words like stress and burnout to reflect this whole territory, and they're insufficient. So one of the ways to think about this is stress is the distance between our values and our behavior. And so if we were to think about where are those instances where there's a gap between what I think I ought to do and what I'm actually doing, it begins to explain why at the end of the day there is moral residue. And I am left feeling as if have I done the right thing? I'm left with the sort of feeling that I failed in some way and blaming myself for things that were absolutely beyond our control. And that is a theme I have seen over and over and over again. Nurses who say, did I do enough? And I want to say, oh my gosh, who could have done more? And yet, holding ourselves responsible for things that are completely out of our control. We did not cause the pandemic. We cannot control it. And we certainly independently cannot fix it. Part of this process of cultivating what I would call moral resilience is being able to turn toward our limitations with some compassion. To be able to be good stewards of our scarce resources, to know ourselves well enough, to know when we've reached that threshold of burden, of stress, of distress, and how we can resource ourselves so that we don't end up with the kinds of sequela that will take incredible effort to try to heal. And so that's the place where, wanting to engage in a different kind of reflection, to change the narrative. Burnout is a victimized narrative. I think we need to pivot toward hope. And hope is not about pretending everything is great. Hope is seeing things clearly and honestly and choosing to orient toward the possibility anyway, even if it doesn't turn out. And so I think part of what is keeping us so distressed is repeating this negative narrative over and over and over and over again. It just solidifies it in our nervous system and our psyche, and we cannot liberate ourselves from it. And so for me, I want to acknowledge that, but I also want to say, and there is also something else that's possible. And can we turn toward that and use that to support ourselves to meet these challenges? Thank you, Ed. It's always a pleasure and very enlivening to think together with you. And I look forward to what we will create as a response to this very important dimension of our work.
Thank you, Cynda. For me, it's been a wonderful journey since our paths crossed some 20 months ago. And I think we need this kind of collaboration. It's not about silos. I think physicians and nurses and other healthcare workers need to come together now more than ever to find solutions, because we're all facing the same problem. I look forward to having many more discussions, many more research projects when we can look to try and understand better the moral distress that our colleagues are facing and how we can find better solutions to deal with it. The literature and the published literature and the evidence in this would suggest that there certainly is a huge gap which urgently needs to be filled here.
Thanks for joining us for this conversation on restoring humanity in healthcare by addressing moral suffering. And our sincerest thanks to Ed and Cynda for leading this very important work. In our next conversation, we look at the use of technology in compassionate elder care with AMS Compassionate AI Fellows Dorothy Kessler and Babak Tati. If you are doing work in the digital technology and AI space in healthcare, please be sure to check out our funding opportunities at amshealthcare.ca. There's more than $1 million available now. And please join us for the next conversation on good tech, compassionate healthcare.